Afternoon. I'm Anna Punga again and introducing this session on Hot Topics 2. Very exciting talks coming up. And the first one from Dr. Shrikant PD, sorry, is a clinical associate professor at the Department of Neurology and Neurological Sciences, Stanford University, who will tell us about CARE MG, physician-reported registry, and the International MG COVID-19 working group. So welcome up.
Good afternoon, and I want to thank the organizing committee for giving me the chance to participate. Oh, let's go back. Yeah, got it. To present this data, I present this on behalf of a large group of you. I think quite a few of you are here. I saw familiar faces from the spreadsheet, and as we look at the data, and some of you are on the committee for this group. And so thank you so much for all the inputs over the last 2 years. And thank you for MGFA for asking us to present some of this data. MGFA helped us throughout the course of this project, and it also funded for some of the administrative costs. Those are my disclosures. And this is the MG steering committee, and I want to make sure, again, I acknowledge a large sort of group of physicians in Northern America, Europe, Australia, Asia, as you can see. And all of them had really valuable input, both in terms of how to take this forward, also sort of recruiting case reports from their local areas. And without their support, really would not have been possible. And so I know nobody wants to really think about COVID and how things were a couple of years ago, but I'm going to ask you just for a second, sort of imagine yourself in March 2020. At least that's the position we were in when this topic came about. And this is really relevant perhaps today, at least for US, not to be US-centric about this conversation. I saw it in the news that US was about to hit 1 million deaths today or this weekend. And it's a sobering sort of place to be in. And so there were a group of us who were worried about our patients getting COVID and what would be the outcome be. And so I think some of us basically exchanged emails from various meetings, and we all sort of got together and we tried to we were worried about what was happening across the country. Patients were asking, can I take hydroxychloroquine? Can I take azithromycin? Should I be taking this proactively? And so we thought we would at least come out with a statement, guidance statement on management of myasthenia gravis. Out of that sort of creation of that statement, we kind of decided we need to know more data about this. Our statement is all good, but we need to get some actual data to sort of help decide what's actually happening to the patients. And as preparation for this talk, I was reading that guidance statement last weekend. And even though I think that was the fastest thing I've ever been involved in, I started writing it. I think a group of us started writing it on Friday night. And then by Sunday night, it was done. Somewhere along, I probably contributed a little bit, I think. But, and it still seems relevant. I don't think we made any major mistakes in the way we wrote that. And so out of that sort of association of group of us, we try to create this registry called CARE MG registry. It's a physician-reported international registry. We decided that we wanted to be physician-reported, mostly because we wanted to get a kind of a quality type of data that has definitive MG-specific information that a physician might be in a good position to report. And we also wanted to get sort of a global outcomes from patients with MG when they develop COVID. And so I'll talk to you a little bit about what this involved. Again, physician-reported only cases. And the reason I emphasize this because as this project came online and we have data online, we've had many requests from patients asking to, oh, can I just do the CRF, the case report form, and provide my case for this? And we've sort of discouraged whenever possible and encouraged them to sort of let their physician know to report the case. Inclusion criteria were fairly straightforward. They mostly had to have a laboratory confirmed diagnosis of COVID-19. We allowed, at the beginning at least, there were some cases of suspected COVID-19. Sort of put yourself in that position of spring 2020. At least in US, I can tell you that not every place had access to COVID-19 testing reliably. So we did include that option of definitive suspected COVID-19 cases. And then the MG specific information, the diagnosis was what we classically use in any clinical trials regarding whether they have myasthenia or not. And we asked for certain MG specific demographic data that I'll show you. Some of you might be wondering, well, I wish you'd gotten more detailed data. You have to ask yourself when we are asking faculty and physicians to volunteer their time to donate their time essentially to report cases. You have to ask yourself, how much depth do you want versus how many cases you want? Because you cannot have both, because time for all of us is limited. We encouraged cases a few weeks after the event happened, just so that we can actually get a true outcome data. We specifically do not have any patient identifier. So if any of you have done this kind of study, for example, this was a unique one for me to learn some of these things. If you ask for a date of birth, that becomes an identifier, and that really raises the level of sort of how much IRB approval you will need. But if you ask for an age, it's not an identifier. And so a lot of the questions we asked sort of replicate one for the other. We initially had a local institutional review board approval at Stanford and at Duke. And then we also had a central IRB later to make it easy for everybody. The study was modeled after MS, rheumatoid arthritis, inflammatory bowel diseases. They were maybe 2-3 weeks ahead of time in terms of starting this process for their patients who are on immunosuppressive therapy or otherwise. And so we used a very similar format. And so the first case report for CARE-MG happened in April 2020. And we published a sort of early analysis after 3-4 months just to get the word out. This was published in Lancet. At the time, the cutoff was October 5th. We had about 90 cases. And at the time, the mortality was about 24%. Incredibly high. And I actually thought, well, we're probably just getting the selection bias. We're only getting cases with really poor outcomes. And some of that panned out to be true, but perhaps not to the extent that I was hoping it was, as you'll see. And so in this presentation, I will show you data until December 1st, 2021. So 4 or 5 months ago as a cutoff. To that date, we had 469 case reports. We chose December 1st only because, as most of you know, there have been many waves of COVID-19. The latest wave that happened late December and January with the Omicron variant, perhaps as a milder phenotype, maybe the variant itself has a milder phenotype, maybe it's the effect of sort of significant vaccination in the community and patients. Either way, we did not include that cohort for this presentation. So this presentation, I'll show you a lot of data, and I'll try to sort of point out the important features. I'll show you some overall outcomes of all the patients that, that we have case reports on, some of the risk factors for poor outcomes of COVID-19, and then MG worsening with COVID-19. And so this is a distribution of cases across the world. It shows you sort of, we would have liked to have a little bit more those blue dots, let's say in Northern Africa or Southern America. I think we don't have anybody from Australia, but they have had, I think, relatively low number of COVID cases. More than 50% of the cases are from US and UK. Usually at this point, I normally point out at Saju is here somewhere, sort of telling him how US is leading UK, but this is not something I think we should be proud about, but it's the reality of it. This is the MG specific data. So mean age was about 54 years. We had about 50% of the patients were above age 55, and then 1/3 of the patients were above age 65. Most patients were AChR positive, as you can see on the right side. About 80% of the patients were AChR positive, about 5% were masked, and then rest were either LRP4 or seronegative. I have some ethnicity data. Most patients, almost 90% of the patients, as you'll see on the right bottom column, bottom table, about 90% of the patients were generalized MG, 40% of the patients had thymectomy, and about 15% of the patients had history of thymoma. Age of onset was about 43. So on an average, patients had disease for about 10 years at least in this data. This gives you a sense of where these patients were before they had COVID-19. We specifically asked for MGFA status the last clinic visit before they had COVID-19. And so as you'll see, most patients were either asymptomatic, had ocular MG, or sort of a milder form of generalized MG, with 23, 21, and 35%, all of that basically making up asymptomatic 1 or 2A or 2B. And then sort of some of the other patients were sicker. There might have been patients who were diagnosed after they were hospitalized, for example. That's why you have some patients with 5. Just give you a sense of what kind of therapies they were on before they had COVID. Very small percentage of patients, about 7% of patients who were on symptomatic, which is pyridostigmine only, or no therapy. Most patients were on prednisone, 56% of them. There were patients on mycophenolate and azathioprine. And then some of the other agents less commonly used. We did have about 30 patients on rituximab, 50 on IVIG, and then some of the less commonly used agents. I do want to clarify this. It's possible that there were patients who were on more than one agent, and I'll show you a little bit of data about that later in the slides. There were patients who were on prednisone plus azathioprine, prednisone plus mycophenolate, prednisone plus other agents, and I'll show you some outcomes. And then we also had few patients who were actually in a clinical trial, and if anybody is interested, we didn't specifically ask for what clinical trial they participated in, because that would have opened up a sort of Pandora box that I just really did not want to stop them from reporting the cases. If you had followed COVID literature, one of the sort of key factors of sort of poor outcome in COVID tends to be comorbid conditions, irrespective of whatever disease that you have, and then the disease influence on COVID outcomes. So we also collected comorbid conditions, cardiovascular disease, pulmonary disease, hypertension, diabetes, obesity, and history of smoking. And you know, about 1 in 5 had diabetes, 40% fell in the obesity group. And on the right side figure, we also looked at, instead of just looking at what they have, we also looked at the number of comorbid conditions, because there is more and more literature that the number of comorbid conditions makes a difference, as in higher the number of comorbid conditions, irrespective of combination, leaves you at a sort of a poorer, at risk of poorer outcome. And so you will see the distribution there. About 33% of them had more than 2 or more than 2 comorbid conditions. What happened? How did they come about the COVID-19 diagnosis? Most of them had laboratory confirmed diagnosis, well above 90%. It's a small percentage of patients who are clinically suspected. And some of the COVID-specific therapies that were given, most common was sort of corticosteroids, which was, and it's still standard practice if you're hospitalized. Remdesivir was also used. And then there were some patients, as we worried about, sort of concern about the whole COVID and MG, there were some patients on hydroxychloroquine and azithromycin, and you will see the distribution sort of covering some of the less commonly used agents. So the first piece of data is to show you what happened to them after they had COVID from a myasthenia point of view. So if I have myasthenia, I get COVID, what happens to my myasthenia? And so the first column there at the last clinic evaluation before COVID-19 gives you the distribution of MGFA before they had COVID-19. As you can see, most patients fell in 0, 1, 2A, or 2B. And then if you go to the second column, COVID-19 worst status after sort of COVID-19, the MGFA status, there are a lot more patients who go into the higher sort of grades of MGFA with 3, 4s, and 5s. And the figure on the right side, the blue shows you what was the COVID-19 status, sorry, the MGFA status before COVID-19, and then orange shows you MGFA status after COVID-19. Sort of rightward shift of the numbers again shows you that there's a clear worsening. Altogether, about 30% of the patients here either had MG worsening, a crisis, and they ended up requiring specific immunotherapy for MG, including a sort of higher dose of corticosteroids, IVIG. Most of the time, a small proportion of patients had plasma exchange to treat their MG worsening. These are some of the overall sort of bigger goal views of outcomes in these patient groups. So about 50% of the patients were hospitalized. Pretty remarkable number. So if you have myasthenia, you have COVID, you have 1 in 2 chance of getting hospitalized. About 1 in 5 were admitted to ICU. Some of the distributions for intubation, pneumonia, sepsis are also available. And the more important thing was that there were 53 patients had died. So that comes out to about 11.3 mortality rate. This, imagine when I originally showed you some of the early cutoff data, it was about 25%, and I really thought it was going to be sort of a bias reporting, but this mortality rate of about 10 to 11 seems to be there, and I'll show you a little bit more data about how that might be the ground truth, as it were. And so the next few analysis, and this has become standard of practice in lots of the COVID literature. So you look at patients who were either hospitalized or died as sort of one poor outcome, and those who were not hospitalized or alive as the other column in the outcome. And I'll show you various features that might decide what happens to your patient. So first thing, we wanted to see if the year of the diagnosis would make sense, because we have 2 years worth of data. And in general, 2021, we had less number of COVID reports compared to 2020. Would make sense. I would hope that is the case, obviously. And then the potentially the hospitalizations also maybe went down a little bit in 2021 compared to 2020 as you compare to the overall number. So that's good, even though it wasn't necessarily statistically significant. In general, as you're looking at the figures on the right, blue is good, my favorite color. Orange is not so good. So if you just want to look at the colors, that would be the way to go about it. This is looking at outcomes based on age. So age is a huge factor in any COVID-based study and overall outcomes. So you'll see the table with the decade. Non-hospitalized and alive is one column, and the bolded column is hospitalized and alive. And so as you will see, as patients get older, from like a decade of 2030, where it's 1 in 5 chance or 1 in 4 chance of getting hospitalized, and as you go to 60, 70, 80 or higher, essentially the chance goes significantly high, 70, 80%. I will grant that we only had 4 patients above age of 90, but essentially all 4 were hospitalized. And we also looked at sort of the cutoff at age 55. And essentially, if you were above the age of 55, you're about 2.59 times more likely to be hospitalized compared to below that age group. And the graph there basically shows you the likelihood of hospitalization as you get older. We looked at hospitalizations or death based on comorbidities. Again, we'll show you the figure on the right will show you that as you have higher number of comorbidities, there's definitive increase in the likelihood of hospitalization. And the table below will show you that both comorbidities and age independently influence the likelihood of hospitalization. They're not just a marker for each other. We were also, being myasthenia clinicians, we were also keen to understand if the MGFA status itself decides poor outcome. So there's the feeling that if you are in a poor MGFA status and you got COVID, you'll probably do poorly, perhaps. And so you will see that the bolded numbers, for example, patients who were non-hospitalized generally tend to have a lower disease burden in the grades of MGFA, grades of 0, 1, and 2s. And the patients who were hospitalized generally tend to have a higher disease burden. Again, the bolded terms on the right side. And some of us were curious, and this came out of the steering meeting committee, and I really thank for the suggestion here. We were curious as to see if the MGFA-A, so 2, 3, and 4 with an axial predominant symptom burden versus bulbar predominant symptom burden, would that make a difference itself? And if you look at the data, it looks like having a B-type symptomatology certainly increases the risk of sort of hospitalization if you were to get COVID compared to sort of a predominant axial pattern of weakness. We also looked at sort of the risk of hospitalization or death based on what prior therapy they were on. As I mentioned earlier, patients might be on more than one agent. I bolded a few things just to get the conversation going. There were some patients on plasma exchange. Maybe they were poorly controlled. They were on plasma exchange, had poor outcome. There's a decent number of patients on mycophenolate, small number of patients on rituximab. And then I also bolded azathioprine because it's a commonly used agent. The figure on the right shows you combination therapy. So the first two bars shows you prednisone and azathioprine. Second one shows you, two bars shows you prednisone and mycophenolate. The third one shows you prednisone and all the other agents they might be on. And at least with, it seems to be in our data and other studies, mycophenolate might leave you at a slightly higher risk in terms of viral infections. Response to vaccination might be poorer with mycophenolate compared to other agents. And some of this pans out in our database too. We also did a logistic regression because we have so much data, try to see which ones are actually truly predictive of poor outcome. And among all the things that were looked at, older age, higher number of comorbidities, which have been proven in multiple COVID studies across the spectrum, were poor measures of poor outcomes, same in myasthenia, but higher grade of MGFA certainly panned out to be a measure of poor outcome in our reported cases. We didn't necessarily find any specific signaling in a logistic regression regarding regarding rituximab, but other agents that I know have been shown in other longitudinal surveys. And then I'll show you a couple of pieces of data. We were curious about remdesivir to see if remdesivir decides what happens to COVID outcomes with remdesivir. This is very difficult to interpret only because right at the beginning, it was only given for hospitalized patients, so it might not be as valuable in this analysis. We also looked at hydroxychloroquine and azathioprine, and as you will see that patients, the likelihood of getting either hydroxychloroquine or azathioprine is definitely higher if you're hospitalized. One of the caveats, of course, is that we did not specifically ask if they got these drugs before they were hospitalized or if they got it after they were hospitalized. It's definitely possible they were doing poorly and they were given all kinds of agents, try to get them better. And so some of the key lessons from this registry, there's definitely higher mortality in MG compared to some of the other diseases with similar immunotherapy. Some of the factors for poor outcomes I mentioned, at least in our analysis. And I feel like, it's my personal views perhaps, is that there might be some disease-specific features in MG itself or the way we use immunotherapy that leaves our patient population at a higher risk for poor outcomes. We do have some limitations. We don't have more detailed MG status data. We only have what I had shown you, sort of pharmacotherapy, broad spectrum MG status. There could definitely be selection bias. I'm pretty sure there is selection bias. We don't have any vaccination data, at least for 2021. And I'll leave you with a table at the bottom, just gives you a sense of the mortality rate across multiple other diseases. And some of these studies, so the COVIMES and the SECURE IBD and the TNF used in immune-mediated disorders, they all are similarly designed studies as this. In fact, I'll say that we were a few weeks behind COVIMES. COVIMES is COVID in MS study, and SECURE IBD was a few weeks ahead of COVIMES. And so in those diseases, at least in MS is about 3.3% mortality, IBD 2%, immune-mediated disorders who were on TNF alpha 3.1%. And MO seems to be high. Perhaps the denominator is not high enough. Possible. There were only 70 patients in the study. Our MG, which is in the red, shows you 11.3%. There is one, at least, publication to date, the very last column on the right, which was looking at electronic health records of patients with myasthenia and COVID-19, both those codes available for patients compared to other patients without myasthenia, but had COVID-19, and the mortality in that cohort was 10.6. So as much as it's possible that we have a selection bias, we might be very close to the truth in terms of poor outcomes in myasthenic patients. And then I just want to finish out by acknowledging the large group of people who made this possible, including MGFA for all their support, hosting the website. Gary Cutter, and I haven't seen Gary today, but Kevin from Duke for making it all happen. Richard Novak, Saiju, and Jeff Guptal, who've been sort of primary drivers for making this all go together, and all the committee members and all of you who submitted cases, took time out to complete this. I think this is a valuable product, and thank you very much.
Thank you very much. Thank you very much for this timely talk. I'm sure it will be interesting questions later on. So moving on to another hot topic, exercise in myasthenia, something we should look into more, I think, and talk about. So Dr. Simone Birnbaum is a research physiotherapist at the Institute of Myology in Paris, France, and she will inform us about the benefits and tolerance of exercise in MG through a randomized controlled MGEX trial. Welcome.
So hi everyone, thank you Anna, and thank you to the organisers for inviting me. I'm really happy to be here. It's my first MGF meeting. And a special thank you to Angela Vincent because she looked through all the records dating back to 1965, I believe. And this is the first MGFA meeting where we talk about exercise. So I'm really excited to be the first person to talk about it and that exercise is on the program. And I hope that I can set a precedent that it's on the program in the next meetings as well. So Anna introduced me, so I don't have anything else to say about me. That's the hospital where I work. So just because it is the first time, I think that's important just to run through a couple of brief definitions about what exercise is and what it isn't. So exercise, physical activity is the umbrella term for any bodily movement produced by skeletal muscles. So basically incidental exercise, carrying your shopping, going upstairs, walking to the bus. Whereas exercise is an activity that is structured, planned, repetitive, voluntary, active, with a specific aim of improving one's health and fitness. So when we talk about exercise training in terms of research, exercise is considered as a complex intervention because there are multiple exercise and non-exercise components. If you think about the exercise training programs, you have to consider the time of one session, the time of the program, the frequency, how often, how many times a week, how many times a day, how many times a month, the type of training, whether it's strength training, aerobic training, or a mixed program, which body part or body parts are involved, the intensity, how do you measure it, how do you, which intensity do you choose, whether the program is individually tailored or standardized, whether it's supervised by a coach or a therapist, or whether it's self-guided by the patient, whether it's performed in a group or alone, which setting, so home, hospital, fitness club, or community. So there are just so many parameters, which makes it quite complex, which makes it a complex intervention. And the other thing I want to mention in terms of exercise and research is that exercise is a voluntary activity. So unfortunately, with research, there's a methodological limitation in that we can't blind participants. So we can only have simple blinding studies. So all of that said, as complex as it is it worth it? And I believe it definitely is. And I think that hope that you do as well. The literature tells us that there are clear benefits of exercise for healthy individuals as well as various patient populations. Exercise is capable of decreasing the risk of multiple chronic diseases simultaneously. That's cardiovascular disease, diabetes, cancer. There's reduced mortality with exercise. It's even been shown to be as effective as some medicine for managing certain chronic diseases. There are benefits, both physical and psychological. It's a safe intervention and it can be performed throughout the lifespan. So what do we know about exercise training in myasthenia? So historically, it was considered as a trigger to worsen symptoms and potentially exacerbate the disease process. It wasn't just myasthenia, it was across the range of many neurological conditions like stroke and multiple sclerosis. There was never really any evidence to support this dogma. However, there wasn't necessarily evidence to refute it either. There was very little evidence. The first interventional trial of exercise dates back to 1993. Then in blue, the bar graphs, they're case studies. And then there was a second interventional trial in 2014. Neither of them were controlled, and they were very small groups of patients. However, there were no adverse events. There was an improvement in lower limb strength and balance. So we do live in an era of exercise is medicine, and the literature is abundant with studies of how exercise is beneficial in multiple diseases today for improving strength, aerobic capacity, depression, anxiety. In myasthenia, patients, you all know, I'm not going to teach you anything here, they have weakness and fatigability. They also have depression and anxiety, and they have a very reduced quality of life despite all the amazing therapies and treatments that are currently available and the progress you have all made. Quality of life and the burden of disease is still reduced. So what about if a non-pharmacological intervention, such as exercise training, could improve health-related quality of life in myasthenia? So I did forget to mention that none of this was my brain work. The principal investigator is Tariq Shasha for this study, and it was a big group that designed this study and initiated the study. So the MGEX study, the primary aim was to evaluate the effectiveness of a home-based, unsupervised exercise program on quality of life in stabilized autoimmune myasthenia. And the secondary aims were to evaluate the tolerance and impact on physical, psychological, and immune status. So this is the design. So there was a 3-month baseline period, 3-month intervention period, and a 3-month follow-up period. So there was an extended baseline period to ensure myasthenia stability. Randomization was parallel group 1-to-1, and the exercise program was compared to usual care, no other intervention. I just want to mention there were safety visits every month. So for 9 months, the patients came in every month. So it was quite time intensive for us and for the patients. It was a multi-center study. The inclusion criteria consist of male or female patients 18 to 70 years old with confirmed diagnosis of generalized myasthenia of mild to moderate severity, MGFA 2 or 3. The myasthenia had to be stabilized for 6 months prior to inclusion. So that meant that there was a 9-month period of stability prior to the exercise intervention because the 6 months plus the 3-month baseline period. Patients, for practical reasons, had to live in or near Paris because of the visits, the amount of visits there were. And a consideration which you might not have in the US, but they had to have a space for the rowing machine. So you can see in the image, the rowing machine that we used for the intervention, it measures 2.4 meters. So in a Parisian apartment, it just doesn't fit. So that was a huge limiting factor in our recruitment. And the exclusion criteria were pure ocular MG or severe MG 4 or 5, any contraindication to exercise, of course, and also a quality of life that was not too reduced. So if they had a MG score below 15, they weren't able to be included. And we used the validated French version for the MG over 60. So in terms of endpoints, the primary efficacy endpoint was the MG 15F for French. And the secondary endpoint, so in blue, they're evaluated blinded, simple, as I mentioned earlier. So safety and tolerance, looking at the number of exacerbations, adverse events, the difference in dosage of the corticotherapy and anticholinesterase inhibitors. MG severity was measured with the myasthenia muscle score, which is the clinical score used throughout France. The immune status was looked at serum cytokines, psychological status looking at depression, anxiety, self-esteem, and general quality of life and non-specific quality of life. The impact of MG or the MG-ADL, respiratory factors looking at FVC and respiratory pressures, MIP and MEP, and physical parameters we looked at elbow flexion, knee extension, grip strength, as well as fatigability with surface EMG and the 6-minute walk distance. So for the intervention, so I just want to remind you, it was an unsupervised home exercise program. There were a couple of familiarization and training sessions initially. Each session lasted for 40 minutes, and they were asked to do 3 sessions a week over a 12-week period. It was an individualized program in that there was a 10-minute warm-up, but the middle section, the endurance phase, lasted 20 minutes. And we asked, the patients wore a heart rate monitor, and that was the endurance phase. They had to reach their target heart rate, which was 70% of their maximum heart rate. And then there was a 5-minute power phase where they just they did pulls at maximum force, and then a 5-minute cool down period. I think that's you, Eugene. Take it away. So that's what it looks like. That's where we did the training familiarization sessions at a different hospital. So it's a global workout, global movement. So, you know, whether they had more arms affected, legs affected, they could participate, and it wasn't painful, it wasn't uncomfortable, a little bit monotonous for 40 minutes, but I'm not going to comment on that. We used cards that we inserted. Each patient had an individual card, which they inserted into the rowing machine, which recorded the date, the duration, and the distance of their rowing, so we could monitor and have quantitative data of their adherence to the program. So this is what the flowchart looks like for the study. So we screened a lot of patients, and probably the main criteria was not meeting the quality of life and also being able to commit to study visits, because it was really time intensive for patients. We randomized 43. The randomization, the group size is not equal because the randomization was in blocks of varying sizes and completely random. So we ended up having more in the exercise group. We had a couple of drop-offs in the control group, and intention to treat analyses and also case analyses, which we'll see. So for the participants at baseline, so baseline was M3, which was after the 3-month baseline period, so just before the randomization. So nothing too unexpected. We had a majority of women, 93%, mean age 46, slightly overweight, predominantly limb and axial weakness, more than bulbar, but distributed almost evenly between MGFA 2 and 3, predominantly AChR positive. Mean disease duration of 14 years. They were most of them were on anticholinesterase inhibitors, 42% on steroids of low dose, and 65% had a thymectomy and were on immunosuppressors. So for the results for the primary efficacy endpoint, so analyses were intention to treat, they were adjusted to the baseline score. And there was between groups mean difference of 0.9 points, which was not clinically significant, not at M6, which was immediately post-intervention, and nor at follow-up, which is unsurprising. In terms of safety, there were 2 hospitalizations for MG exacerbation in the control group. For MG exacerbations without hospitalizations, there were 3 in the control group versus 0 in the exercise group at M6. Which was not clinically significant, but at M9 at follow-up, it did become significant with 5 exacerbations in the control group compared to 0 in the exercise group. In terms of adverse events and medicine dosage, there was no significance between the 2 groups, no difference. Looking at secondary endpoints, there was an improvement in the MG-ADL for the exercise group of 2 points, almost 2 points, so not quite clinically significant. And there was also an improvement in the 6-minute walk distance. And that was not only clinically significant, but clinically meaningful because it was quite high, also considering that the baseline distance was around 500 meters for the participants, which is roughly 5 kilometers an hour, which for the Americans, I had to look it up, but it's roughly 3.1 miles an hour, which is pretty normal. So considering they had a high baseline level of walking capacity, the fact that they increased is significant. I mean, it was significant anyway, but yeah, it is even more meaningful. These improvements were not maintained at the follow-up 3 months later, which just reinforces the idea that it was potentially the exercise that contributed to this, because at the 3 months post where they weren't training anymore, the improvements were not maintained. Looking at the other secondary endpoints, there was no difference, no improvement between the 2 groups for the exercise. Just when we look at exercise trials, it's extremely important. I mean, when we look at any trials, as you know, it's extremely important to look at adherence, but it's much more complicated with exercise as it's a voluntary activity. Keeping in mind that this was an unsupervised home program, we actually had quite a high adherence rate. We had an adherence criteria, which was 20 sessions out of 36 for at least 30 minutes out of 40. So 70% met the adherence criteria that we defined, And the reasons were not related to the myasthenia. It was they had the flu, they were away for the weekend, had menstrual pain. It wasn't related to the MG. And if you looking at the baseline characteristics, there was no difference between those that adhered to the program and those that didn't adhere. We did case analyses. I'm not sure whether you're all familiar with this, and I'm not the best person to tell you about it, but basically it's a technique that was developed for randomized clinical trials when there are compliance issues. And it's a robust statistical method, and it does show that when you're looking at just the compliers compared to the control and the non-compliers, we did actually manage, exercise training actually managed to improve the knee extension strength as well. So exercise in myasthenia is, I think we can say from MGX, it's the largest randomized control trial to date. Whilst we weren't able to show an improvement in the primary endpoint, which was the health-related quality of life, we did show that it was well tolerated and safe, and there were improvements in some secondary endpoints. Since MGX, there have been some other trials, which is really exciting in this field. So you can see on the bar graph, the number of trials, like in 2021, number of trials published was 3. So it's increasing. Although you can see under each bar, the number of patients included. So they're very small trials. Most of them are uncontrolled, and they're pre-post design. So they do have methodological limitations. However, no one has reported significant adverse events. Their lower limb strength has increased, functions increased. There's been a reduction in fatigue perception, and there's an increase in confidence established, which is also really, really important, I think, for these patients. So it's really promising. So my take-home messages, I still have a lot of questions. I don't know about you. We don't know. I mean, it's kind of throughout in exercise, in chronic disease, what type of exercise, which one's better, strength, aerobic, who knows? So we really we can't tell you that for now. It depends what we want to improve. And do we want to improve strength, or do we want to improve function and quality of life? Ultimately, that's what we want to improve. So we don't know what type of exercise is the best at this stage in terms of research, in terms of evidence. We don't know which dose. I'm wondering about the protective effects of exercise, because if we look at case studies, and they're not all published, I've got some anecdotal evidence, people that do high intensity exercise seem to do better. They really, they're better when they exercise. When they don't exercise, they're not as good. I don't know. So I'm just wondering about protective effects, which I think that needs to be explored. I think that would be really interesting. I'm also interested in the relationship with therapy. Could exercise enhance the effects of therapy? What's the relationship? So I just want to conclude by saying evidence clearly supports exercise as a therapy or adjunct therapy in well-regulated myasthenia. And I've got a study at the moment of a survey of patients in France. So it's self-reported, but there's a large group of patients. So there's 405 people who've participated so far. Just below half don't exercise compared to half, it's kind of half-half. There's a large group of people that stopped exercise completely once they were diagnosed with myasthenia. And a lot of them want to go back to exercise. And one of the limiting factors is a fear of exercise. So I think it's really important that it's our role as health professionals, doctors, treating physicians, to assist these patients to get back to exercise by just reassuring them, educating them and reassuring them. Maybe I know that some clinicians prescribe exercise. So if that's what you do and that's the most effective for you, whatever works. But I really think that whilst we don't have 1,000 clinical trials of exercise, I think that we've got enough evidence to say that it is safe in well-regulated myasthenia, and it's our role to transmit that to patients and to help them move forward before they get more deconditioned. So I want to thank you all for your attention, and I do want to acknowledge so the funding, we were funded by a grant from the APHP in Paris. All the trial participants, which were really committed and dedicated. The MGX team, all the staff, the immunologist, Rosen's here, the investigators, Sophie's here, and of course the PI, Tariq, and as well as all the support staff and my colleagues at the lab, and that's all. Thank you so much.
Thank you very much, Simone. I think we'll have a lot of interesting discussion at the Q&A session. So next speaker will be Dr. Tarek Shashar, professor and senior consultant at the Institut Pasteur Department of Intensive Care, Paris. He will present the comparison of corticosteroid tapering regimens in myasthenia gravis, a randomized clinical trial. Welcome.
Okay, good afternoon. And I would like to first thank the organizer for having invited me to present you our randomized clinical trial on corticosteroid tapering in patients with generalized myasthenia gravis and treated with azathioprine. It is well known that corticosteroid is a first-line immunosuppressive agent that we propose in patients with generalized myasthenia gravis who do not respond to pyrostigmine. And we know that steroid is good for myasthenia, but not so good for patients, as we know that it is efficient, that it is improving the control of myasthenia gravis, as it has been shown by Professor Evoli a long time ago. But we know also that it is associated with various and severe side effects, including Cushing aspect, gain of weight, diabetes, hypertension, osteoporosis. And we know that there is a relationship between the frequency of side effects and their severity and the cumulative dose of steroids. So the question was, how can we reduce the cumulative dose of steroids in order to decrease the occurrence of side effects without destabilizing the myasthenia gravis? And this is a very famous study done by Pallas and Newsom Davis a long time ago, showing that azathioprine can allow to reduce the cumulative dose of steroids and improve the control of myasthenia gravis. And a few years afterward, it has been shown that thymectomy also reduced the cumulative dose of steroids at 3 months, 3 years, not 3 months, at 3 years, with also a good control of myasthenia gravis. So as you see, cumulative dose of corticosteroid is often used as a primary endpoint and therefore a criteria for assessing a given intervention efficiency. So we reasoned that if a corticosteroid are a first-line treatment of generalized myasthenia gravis, if discontinuation of corticosteroid is a major goal for physician taking care of myasthenia patients, and if a cumulative dose of corticosteroid is a component of primary endpoint for assessing the benefit of a tested intervention, including azathioprine, thymectomy, or now new immunosuppressive agents, therefore, we must determine what is the best way to taper corticosteroid in MG patients, given that so far, azathioprine is the most associated non-steroidal immunosuppressive agents with corticosteroid, and it has been shown by Pallas that it facilitates the corticosteroid tapering and it allows to well-stabilized myasthenia gravis. So there are various regimens, but none of tapering, of corticosteroid tapering, but none has been assessed so far. The most applied regimen, notably in clinical trial, is the one developed by Pallas and Newsom Davis in 1988. And this is a good, well-described tapering regimen, but however, it is associated with a high cumulative dose of steroids, with a mean daily dose of prednisone exceeding 30 milligrams per day at 15 months and 20 milligrams per day at 36 months. So we decided to develop another regimen, a more rapid tapering regimen, and to compare it to the referent slow regimen developed by Pallas and Newsom Davis. So the main characteristic of a rapid tapering is immediate high dose of prednisone, daily dosing of prednisone, earlier tapering initiation when the patient attains first clinical improvement, and a faster tapering that I will shortly describe later on. And in comparison, while in the slow regimen, the increase of prednisone, initiation of prednisone is slow. It is an alternate day dosing, and the tapering is conditioning by the attainment of minimal manifestation status, and it is a slow tapering. So in our regimen, as you can see, there was a very rapid decrease at the beginning and then a slow decrease by 1 milligrams per month at the end. And in the best case scenario, prednisone will be discontinued on 300 days in the slow tapering regimen and before day 200 in the rapid tapering, in our rapid tapering regimen in a patient with 60 kilograms of weight. So what is the study design? This the design of our clinical trial. It is a randomized clinical trial, multi-center, second-blinded, meaning that the MG status was assessed by blinded physicians that then provide the MG status to another physician called the prescriber, who prescribe according to the MG status the steroids. And the patients were monthly follow-up up to month 12 to up to 1 year, and then at month 15. All patients were treated with azathioprine, and in case of side contraindication to azathioprine, they were treated by mycophenolate mofetil, and of course, IVIG and plasma exchange were allowed in case of acute exacerbation. So the primary endpoint was the proportion of participants or patients having reached minimal manifestation status without prednisone at 12 months and having not relapsed or taken prednisone between month 12 and 15 months, because we thought that we could, reduce or stop, corticoid very rapidly, but with a risk of relapse. And this is why we added 3 months of follow-up after discontinuation up to month 15. The other secondary endpoints included the cumulative dose of prednisone over 12 months, but also the proportion, the rate and time of MG exacerbation and the type of rate of prednisone-related complication. So this is the flow chart. 117 patients were included, 58 in the slow tapering group and 59 in the rapid tapering group. This is a characteristic of the population, and as you can see, all the patients have a generalized myasthenia gravis, and the MG status didn't differ between the two groups, and most of the patients have anti-acetylcholine receptors positive, and a third of the patients have underwent thymectomy. So the proportion of patients who attained the primary outcome was significantly higher in the rapid tapering group than in the slow tapering group, 30% versus 9%, and meaning that in 40%, the patients were in minimal manifestation status at 12 months with no steroids at 12 months and 50 months. So, and the rapid tapering groups, the rapid tapering regimen allowed to reduce by 2 grams over a year of the cumulative dose of steroids, and so to reduce of 5 milligrams per day. The reduction is of 5 milligrams per day in average, which is quite clinically significant. And what we found also is that most of the patients at 50 months have a very low MG-ADL, so a good MG status according to the score. But as you can see, it was significantly higher in patients with rapid tapering, included in the rapid tapering regimen, even if it was below 2. So, and there was a trend to a greater number of serious adverse events in the rapid tapering group, even if it was not significant. We do not have a clear explanation for that. And in conclusion, Our study showed that corticosteroid can be more rapidly decreased in patients with generalized MG treated, generalized myasthenia gravis treated with azathioprine and without destabilizing MG. The rapid tapering regimens enable a clinically relevant reduction of 5 milligrams per day of corticosteroid. And what is interesting is that the azathioprine was more effective in terms of corticosteroid tapering and MG control than previously reported. And so I think that this is a major information if we want in the future comparing, the new immunosuppressive agents with azathioprine, which is still the reference drugs. So I think that this is an important result of our trial. And but of course, as any study, it has several limitations. It's single-blinded nature. It was really complicated to make a double-blind randomized clinical trial. And there was a short follow-up duration, maybe 15 months, it's not enough. Maybe we should have gone for 18 months or 2 years. But well, this is highly time demanding and also require a lot of money to conduct this kind of study. There was no difference in MG status at 50 months. So we can say that, okay, whatever the regimens, at 50 months, everybody is fine and have a very low dose of steroids. So, and there was no assessment of the quality of life. And we know that it's now very important, and especially, and we know that steroids can really affect patients and their quality of life badly sometimes. What is the perspective? Can we do faster than faster? So should we develop a new tapering regimen? Should we try to even propose no steroids in our patients? This could be the ground. And maybe if we have to test these new immunosuppressive agents, maybe they are more efficient in terms of reduction of steroids. And but for the moment, they have not shown, I think to my knowledge, that they are really sparing steroids. For instance, in the ADAPT trial, the steroid dose was not changed over the study period. Could we test non-pharmacological intervention? Of course, we are not believer, but convinced. We were believer, but now we are convinced that maybe exercise could be helpful. And I would like to say that Simone has done everything, so she was really the master of the MGX pilot randomized clinical trial. And so this is the conclusion. The rapid tapering of prednisone therapy appears to be feasible, beneficial, and safe in patients with generalized myasthenia gravis. And so maybe, of course, we can test this regimen in other autoimmune disease, but I think that it could be useful for designing future clinical trials in myasthenia gravis patients. And of course, I would like to acknowledge, to thank all my collaborators, and especially Simone Birnbaum. She is very important in our research, and Raphaël Porcher, who was a statistician, and also Sophie, who included a lot of patients from her unit. And thank you very much for your attention.
Thank you very much. Interesting talk. So coming up, Dr. Amanda Guidon, a neuromuscular neurologist, is a Massachusetts General Hospital and assistant professor of neurology at Harvard Medical School. And she will tell us about MG that can arise from treatment with checkpoint inhibitors. Welcome.
Great. Thank you so much for the introduction, and thank you to the committee for the invitation to talk on this topic. I'd also like to acknowledge that we're at the last talk of a wonderful meeting. So thank you so much for everyone who's gone before and given wonderful presentations. It's been fantastic. So this is a topic that is very interesting. I find it one of the most interesting subtypes of myasthenia. So I'm excited to talk to you about this today. These are my disclosures. So first, I'm going to introduce immune checkpoint inhibitors, talk about the mechanisms, the indications, response rates, and side effects briefly as an introduction to the topic. So there are 8 immune checkpoint inhibitors that have been approved by the FDA in the US for treatment of cancer that fall into 3 categories, depending on the immune checkpoint they target. CTLA-4, which was the first in class, and it is named ipilimumab, and then anti-PD-1 and PD-L1. Pembrolizumab and nivolumab are the most commonly used for the greatest number of indications. When it's a bit hard to believe, but now we're 10 years in to this field, over 10 years since the first FDA approval. And initially, ipilimumab was approved for unresectable metastatic melanoma and really sought to replace the other immunotherapies which had been used in melanoma previously. In 2014, anti-PD-1s were first approved, and they were used as monotherapy, but then also as combination therapy in these melanoma patients. Since that time, there's just been a large number of increased indications for these therapies, and most notably in 2018 was the first approval for common cancers like lung cancer, and more recently it has been approved for some types of triple-negative breast cancer. And I want to show the response rates in different indications because I think it's really important as neurologists to keep in mind, what influences the risk-benefit discussion that we have with these patients. So in some cancer types, there's a very high response rate. These are advanced cancers, and there's a greater than 50% response rate. And then there's some cancers where the response rate, which is expected, is significantly lower. So how do these immune checkpoint inhibitor therapies work? Well, T cell activation in the lymph node requires both immunologic signal 1 and 2 on the left side of the diagram, and binding of CTLA-4 by the dendritic cell ligands blocks immunologic signal 2 and therefore inhibits T cell activation. When an anti-CTLA-4 drug is introduced, it then binds and disrupts the inhibition from CTLA-4, thereby activating T cells. Similarly, binding of PD-1 by one of its ligands, PD-L1, blocks TCR signaling and therefore similarly blocks T cell activation. When there is antibody blockade of PD-1 by a drug like pembrolizumab or nivolumab or one of its ligands, that permits T cell activation. So all types of immune checkpoint inhibitors result in increased T cell activation. And this is the effect that is targeting the cancer, but there can be off-target effects. And those off-target effects are called immune-related adverse events, and they can affect any tissue in the body, any organ system, and including neurologic immune-related adverse events. So what are the mechanisms of immune-related adverse events? Well, it's unknown to date, and it's unclear whether the mechanisms of efficacy are the same as toxicity, and therefore whether biomarkers of one may serve as a biomarker of the other. Possible mechanisms include increased T cell activity, which we talked about, activation of T helper cells, which leads to B cell activation and proliferation of antibodies secreting plasma cells, and then antibodies directly targeting cell surface antigens. So what is the immune-related adverse event frequency? Well, overall, they're pretty common. So most patients will have an immune-related adverse event. So dermatologic immune-related adverse events, pulmonary, GI are some of the most common. But the severe immune-related adverse events are less common, and even less commonly, patients actually need to stop therapy. Death is rare from an immune-related adverse event, but the most serious and most likely to lead to death are the cardiac and neurologic immune-related adverse events. And so what is projected in the future for administration of immune checkpoint inhibitors, and what does that mean for the patients who we'll be seeing as neurologists? Well, there are almost 700,000 patients per year in the US who are eligible to be started on ICIs based on their cancer indication. If we estimate an incidence rate of 1%, which is a low estimation for neurologic immune-related adverse events, that equals over 4,000 patients annually, and then 2/3 of those are in the peripheral nervous system, and about half of those are myasthenia based on population studies. So we're really talking about over 2,500 patients per year with new onset of myasthenic syndrome related to immune checkpoint inhibitor, which is similar to the incidence in the US of idiopathic myasthenia annually. So now we're going to talk more in detail about immune-related myasthenia gravis. So when did this first start to be reported? So I actually saw the first patient who had an immune-related neuromuscular junction disorder in 2014, and we presented those two patients at the 2015 MGFA meeting. And at that time, there were 5 patients reported in the literature. And then over the subsequent years, with close collaboration with our oncologists, our melanoma group, and our inpatient oncology director, Dr. Carrie Reynolds, we really grew our understanding of these disorders and saw patients rapidly in whom these events were suspected. And so what do these patients look like? Well, it's myasthenia, but it's different. It's not the same clinically, and it does not respond the same way to therapies. So to give an example of a patient who I saw earlier this year, this was a 76-year-old man with renal cell carcinoma. He had 1 dose of pembrolizumab. Previously, he had had a history of fluctuating ptosis for 9 years with intermittently low positive titers of acetylcholine receptor binding antibodies, but he didn't have a lot of access to medical care. He had no other workup or ongoing neurologic care, and he was minimally affected by his ptosis. It's unclear if that history was known at the time of ICI initiation. He underwent infusion of pembrolizumab and then 2 weeks afterwards developed chest pain. And that chest pain brought him to the emergency department. He was diagnosed with an NSTEMI. During that admission, he rapidly developed bulbar weakness and then respiratory failure. His CK was 2000, and he was diagnosed with an immune-related myopathy and exacerbation of previous myasthenia gravis. He was intubated in the intensive care unit. He received IV and oral steroids, IVIG, and he was still very weak and unable to wean off the ventilator, even though his CK normalized. At that point, he was transferred to our hospital. He was still intubated. His troponin was ongoing at a high positive value. He had a cardiac biopsy at that time, which revealed extensive myocyte necrosis. His electrodiagnostic studies were very limited, but there was mild decrement, those below what we might consider abnormal. And his EMG just showed some spontaneous activity in one muscle. His repeat acetylcholine receptor binding antibody was positive. He was treated with plasma exchange, abatacept for the myocarditis, mycophenolate mofetil, oral corticosteroids, and he had no improvement. He was transitioned to comfort-only care, and he was deceased 2 months after the pembrolizumab. So very different course than what we would often see in idiopathic myasthenia. On the entire opposite end of the spectrum, we recently published a series of 3 patients who presented just with ocular symptoms consistent with immune-related myasthenia gravis, and they had coincident myocarditis, which actually drove the immunosuppressive regimen. And so even though the patient's neurologic symptoms are mild, we have to consider the more potentially serious immune-related adverse events. And so in summary, our immune-related myasthenia gravis patient population based on published reports is generally older, consistent with who is receiving immune checkpoint inhibitor therapies, frequently seronegative in contrast to earlier reports, which had a selection bias towards patients with positive acetylcholine receptor antibodies. And there have been no MuSK patients reported with checkpoint-related myasthenia. LRP4 has not been reported consistently. And the distribution of weakness is slightly different. It's predominantly ocular, which is the same. The bulbar weakness is predominantly dysphagia, so less frequently dysarthria or tongue weakness. Severe facial weakness can be present, neck extension weakness more than neck flexor weakness. So these patients often present with head drop. This has a predilection for hip flexor weakness, even more than other proximal muscles. And then early respiratory involvement is common. Concurrent conditions are an overlapping myopathy and myocarditis, which is common, and an idiopathic myasthenia that's very rare and often associated with thymoma. And the mortality is 20 to 50% when patients present with this triple overlap syndrome with myasthenia, myositis, and myocarditis. However, de novo disease can actually be quite mild when treated, monophasic, and require only a short course of steroids. And so where are we in the history of understanding this condition? So the first case was reported in 2014. And then over the subsequent years, there were approximately 23 patients in case reports. Then there were small case series. There was a series in neurology in 2017 that looked at 12 patients with immune-related myasthenia from multiple centers compared to controls with idiopathic myasthenia. And then there was a change in 2018 when some major oncologic societies produced guidelines for management of these disorders, but the myasthenia itself wasn't further defined. We then in 2021, Dr. Narayanaswamy and colleagues, when they published the international consensus guidance statements, the revisions, there was a mention of immune-related myasthenia for the first time. And interestingly, with these additional reports, which then included a FAERS database from the FDA and a pharmacovigilance database that was published from a group at Vanderbilt, there have been no changes in the ASCO or other guidelines for management of immune-related myasthenia. So this increased understanding and recognition hasn't changed the recommendations for management since 2018. And so I guess I would just say to, interpret the retrospective data on these conditions with caution. We know that the overall, rate of reported neuromuscular immune-related adverse events from large meta-analyses are approximately 0.5 to 5%. And then a meta-analysis looking at neuromuscular complications in patients who'd been treated with just anti-PD-1, including 85 patients, outlined the distribution of symptoms that the patients had and then the diagnoses. But upon further review, the evidence did not support the neuromuscular diagnosis in 13%. And there were, in a quarter of patients, there were signs of additional neuromuscular disorders. So some of these overlap syndromes. And so retrospective data and data based on traditional disease definitions is limited. And we know that all of the FDA reporting and case report forms don't have the ability to be able to report overlapping immune-related adverse events, which really contributes to the severity of these disorders. And so why do we have some additional variability in classification? Well, the myositis can be called rheumatologic immune-related adverse events and not fall under neurologic. Patient selection, so requiring acetylcholine receptor antibodies for diagnosis or elevated CK for diagnosis of myositis. And then calling any ocular weakness myasthenia, when in fact we know that the myositis associated with immune checkpoint inhibitors can present just with ocular weakness. And there were no standardized disease definitions or assignments of levels of certainty. So the examples of current immune-related adverse event reporting has some very basic features, but some key outcomes and treatments are not typically included in the reporting. And a lot of the responses for phenotyping are free text, and so there are not categories that can be harmonized across different studies or with real world data. And this is an example of a case report form. And so in 2017, there was a group of clinicians and researchers at MGH where I work who came together, led by Dr. Carrie Reynolds and Chloe Villani, and felt that we needed to collaborate in a cross-disciplinary way to further understand these events, provide better care to patients, and then begin to really investigate the immunologic underpinnings of these disorders. And in 2019, there was an immune-related adverse event meeting at the NIH, which our group went to. And there was a colloquium which was convened by the FDA and pharma and an organization called Project DataSphere with a call to action for standardization of disease definitions and sharing clinical trial and real world data. And as a result of that meeting, we decided to first tackle the neurologic immune-related adverse events because they were some of the most serious, including myasthenia, and then also because they were rare. So it seemed like a task that could be conquered and serve as a model for other toxicities. So we first planned to create a registry and then decided that before we were even able to create a registry, we needed to really standardize these definitions. So we put together a proposal for this. We're funded by Project DataSphere and then began crafting the disease definitions. And the group at the bottom of neurologists and oncologists wrote an initial draft of the definitions, and then we convened a panel of several dozen members of the neurology community, oncology, at multiple institutions across the United States to be involved in a Delphi process to create these disease definitions. And we were not sure at the beginning whether anyone would reach consensus, but we did manage after a couple rounds, and we produced the consensus definitions, including for myasthenia. So the main piece of this work, which the other parts branch off from, is the overall classification of the neurologic immune-related adverse events, which really provides an organized way to think about it and to standardize describing what we're seeing clinically and immunophenotypically. And so we first divided into CNS and PNS, and we really wanted to have a framework that could be used by neurologists, but also non-neurologists to provide some level of specificity for these events. So first we did a very basic CNS, PNS distinction, and then among that we had 7 subtypes. So meningitis, encephalitis, immune-related demyelinating syndromes, and vasculitis. And then on the peripheral side, neuropathy, neuromuscular junction disorders, and myopathy. And for each syndrome, we had 6 qualifiers. So the subtype, whether this was a de novo disease or exacerbation of pre-existing disease, maximum severity grade, antibody association, whether there was a concurrent neurologic event or non-neurologic immune-related adverse event, and then the level of diagnostic certainty. And we felt like with those qualifiers, we would have a snapshot and more understanding that these disorders could be harmonized across different reporting systems. We also developed general guidance for tempo and timing, how to classify overlap, pre-existing neurologic disorders, and these other categories in really an educational way. And all these statements also reach consensus. So these are the this is an example of one of the disease definitions, and this is for neuromuscular junction disorders. All of these parts reach consensus. And so to go through in detail, we have the specific subtypes. And so for junction disease, it's myasthenia, with either antibodies or no antibody or seronegative, and then Lambert-Eaton myasthenic syndrome, which has been reported in a handful of cases. And then for the non-neurologists, we outline the symptoms, supportive examination findings, both for myasthenia and LEMS, to really use this as an educational document. And then we went through levels of certainty. So we placed a higher burden of a level of certainty to be diagnosed with definite neuromuscular junction disorders, because we know that some patients can have coexisting myopathy, which can really confound assessment. We expected that most people would fall into the probable category. And it is expected that, if somebody's probable and even some possible, will require treatment for the immune-related myasthenia. We also went through the evaluation in terms of what was common or possible to provide guidance on how to evaluate these patients, and then also how to interpret the findings. We adapted the severity criteria from the CTCAE to be specific for immune-related myasthenia and myopathy, to be able to more closely provide examples of what might constitute moderate and severe disease. And then we built a REDCap toxicity database, including the disease definitions for this phenotyping based on the consensus definitions. And we felt that the whole process of the disease definitions and the registry could serve as a framework for other organ systems. And to date, the dermatologic immune-related adverse event group, the ophthalmologists, pulmonary physicians have all started their own Delphi process to create definitions in a similar fashion. For this REDCap database, all neurologic fields are double reviewed, first by a general physician, and then who's extracting the data, and then a specialist to ensure accuracy of diagnosis. And any parts that are uncertain are adjudicated by the larger group. And so this is an example of the fields of the registry. So some are general history, which can be applicable to other disorders for overlap. And then some are specific, and we built in the disease definitions to be able to go through and fulfill the disease reporting criteria. We have a short form, which is very similar to what would be a case report form for the FDA. And so we feel like these are the minimum data elements that would be required to describe these events. So timing, what the disorder is, and then what the specific syndrome name is, and then the different classifications that we talked about, whether the patient was hospitalized, what their treatments were, and then whether they were alive or deceased, and what the cause of death was. And so we have begun to abstract our patient population, and we looked at first inpatients who for over a 10-year period at our one hospital who had been diagnosed with either immune-related myasthenia or myopathy, and began to look at their clinical characteristics. They typically did not have a history of myasthenia or autoimmune disease. And the most common cancer types were melanoma and lung cancer, as we would expect. Remarkably, only one patient was antibody positive, so really a predominance of seronegative patients. Electrodiagnostic studies were abnormal and clinically significant, more commonly in the myositis patients than in the myasthenia patients. And the severity ranged from grade 2 to grade 5. As we expected, most of these patients met criteria for probable myasthenia. And we looked at the chart diagnosis and myocarditis overlap, and 50% of these patients had myocarditis overlap and 60% had other immune-related adverse events. So in the interest of time, I'm going to just click through the remaining slides because I'm hearing that my time is up. And to let you know about the consensus guidelines for treatment, the recommendation for permanent discontinuation with myasthenia when it is present. For our group, we typically start with steroids, and then for more severe disease, add in IVIG and steroid sparing agents as needed, typically for other immune-related adverse events. And there's a real need for additional development of targeted therapies, which don't threaten the anti-tumor benefit of the immune checkpoint inhibitors, but can be more targeted to the underlying pathophysiology of these disorders. We are now looking at retreatment because this is a very common clinical question, and have performed a systematic review, which shows a low rate of recurrence of these immune-related adverse events in patients who are retreated after their initial events, and that's under review. And I think the main question for our patients is, can we treat patients with known myasthenia with immune checkpoint inhibitor therapy if they develop cancer? And we know that there is a high exacerbation rate in the published literature. We definitely need more data about it. And right now it is a relative precaution. We do know from other disorders that patients with non-neurologic autoimmune disorders have the same rates of immune-related adverse events as patients without autoimmune disease. So in summary, immune-related myasthenia is different. I hope that I've conveyed that in clinical phenotype and also response to treatment. We think that the incidence of this is going to increase as immunotherapy for cancer expands, and we're going to see more and more of this. And there's a lot more work that needs to be done in terms of the pathophysiology. It's likely different than idiopathic disease. And hopefully we can really phenotype these patients clinically to make our immunologic investigations meaningful. Distinction from immune-related myopathy can be challenging. They overlap, and remember myocarditis. And steroids are the mainstay of treatment, though high fatality rates are still reported, and data on retreatment and treatment with idiopathic myasthenia who need ICIs for their cancer is really a critical data gap. So thank you to the team at MGH, particularly Dr. Carrie Reynolds, Dr. Malika Eskian, who's our postdoc, and the whole team there. So thank you very much.
So you had a wonderful thing at the last slide, questions, and that's why I will now welcome up all the speakers of this session to the panel on the stage. A lot of questions, so please go ahead.
Yes, I have a question to Dr. Shashar. I was really impressed by your paper because I downloaded a year ago from our university server. But when I look at the two groups, so the slow and the rapid tapering, with the rapid tapering, you started at a much higher dose. The patients get 55 milligrams a day, whereas with the slow tapering, you start at 5, and then you go up to 55. If I look at the total dose, the area under the curve, they're quite similar. Do you have any information on the total dose or the so-called area under the curve of prednisone? I don't think they're different in both groups.
No, there were also difference when we look. We measure the cumulative dose between the two groups. And in fact, the cumulative dose was lower by 2 grams over 12 months between the rapid and the slow tapering regimen. So meaning 2 grams over a year means that we spare 5 milligrams per day in the rapid.
That's little. I mean, so the total it's not significantly different. I mean, if you look at your curve, I don't see a difference.
Yes, but it's not zero because it's not because why? I agree that 5 milligrams when the patient is treated by 60 milligrams or more than 60 or 80 milligrams of prednisone, you can say 0, but when you're decreasing, I don't know, I think that you have this kind of patient, but 5 milligrams when you have 10 milligrams, it's quite huge, in fact. Yeah. So it's, So this is why we think that it's clinically relevant at
Yeah,
5
but
milligrams.
I used to start at much lower doses, except in MGFA class 5. I don't start at this
You,
high doses
you
anymore.
start a lot.
30
Yes,
milligram, yeah.
you know that's.
Just
Yeah.
okay.
The regimens differ. Thank you. So Matja?
Yeah, thank you for these great, inspiring talks, I must say. I have a question for Amanda. Did you ever try to see if these patients' sera cross-react with neuromuscular synapses to confirm that there's an autoimmune response targeted there?
Yeah, that's a great question. So we actually, when patients are started on immune checkpoint inhibitor therapy, if they enroll in the protocol, we bank their blood at that time. And then if they develop an immune-related adverse event, then, if they're enrolled in the protocol, we collect again. So we're developing, really a repository of these samples. We have muscle tissue. We're now collecting CSF. But we haven't looked at that in particular. And I think that would be, really important to demonstrate the abnormal neuromuscular transmission, because I'm not sure that it's the same. So yes, I agree.
Yeah.
Thanks.
Thank you. Next question.
Hi, Amanda. Tassin Mozafar from Irvine. And I actually, similar question. So I've been following these patients for 3+ years, and I'm still not able to convince myself that there is such a thing as myasthenia. And the challenge that we face is this: these patients come to the ER, they have droopy eyelids, they get diagnosed with myasthenia, they get admitted, they get put on steroids. Nobody bothers to check a CK, and by the time you check a CK, the CK has normalized or reduced. What we have found very useful in this is the MRI of the muscle, which lights up in majority of the cases. So I think in majority, and it's an extreme statement, but majority, it's the myositis that ends up in the hospital rather than the myasthenia. They don't have detriment. And there's a very interesting paper from Andy Mammon's group where they looked at thymoma, and it's the acetylcholine receptor antibody positive patients who get the myositis more than anything else. So I think it's a perfect example of when you see the world from rose-colored glasses, everything looks rosy, and the ER physicians think it's myasthenia. We have relegated myositis to rheumatology. They don't think about these issues as much. But I think I would bet you that if we carefully look, most of these are myositis. And I believe there is a paper that showed that there is inflammation in the extraocular muscle as well. So even the droopiness and the eye movement issues may be a myositis.
I completely agree. And at this point, I have the benefit of seeing these patients often from the beginning. And I think that most of these patients have an overlap, and that it's very, very rare for junctional disease to exist independently. And the primary driver of severity is the muscle disease and the myocarditis. So that has become very clear. I do think, however, there is a subset of patients who are seropositive. It's very rare, and that's probably exacerbation of pre-existing disease that was not diagnosed. And then there is another subset that does have evidence of abnormal neuromuscular transmission. They have decrement on rep-stim. I didn't go in detail into those data, but it's very convincingly abnormal. And so I think that there's a spectrum, and that's why we tried to capture that in the disease definitions, both with the definitions and the level of severity, and why having an acetylcholine receptor antibody in and of itself was not diagnostic in this disorder because of Dr. Mayman's paper. So yeah, totally agree. Thank you for the comments.
Good points. Next question.
So we've heard from several people about the concerns about steroid, and so the tapering is an excellent thing, but I think it's equally as big of a problem is people continuing patients on steroids way too long, then when it's not working, and waiting for a secondary immunosuppressive for months and months. So I'm a big proponent of fairly rapid escalation of steroids. And if they're not working, then just saying this person isn't a steroid responder. And I think that could have probably even more impact than the tapering in terms of sparing long-term steroid side effects. Can you comment?
Comment?
So, maybe I didn't understand everything. You say that you want, if a patient does not respond to steroids, and he requires high dose of steroids, you stop it? Now you stop them, or?
Because I think that's the biggest problem that we see is
Yes,
that
I know.
people say, okay, now we have to put them on a steroid, on the immunosuppressive,
Yeah.
and we're going to wait 6 months while
Yeah.
they're already on a high dose of steroids that they didn't respond to in the first place. You know, so that's,
Yes,
I think
it's-
that's why
it's-
steroids get such a bad name, is because patients are kept on for a year before, you know, they decide, oh, they're not responding.
No, I agree with you, but what I used to say is that, and this is what I said to in the introduction, I think that it's a way to well control myasthenia gravis. We know that the patient, in most of the cases, the patients are responding to steroids.
Yeah.
And the problem is, and some patients, so I think that we have to stop or discontinue our type of steroids as soon as possible. And but we know that we have these patients who require, I don't have so many patients who require high dose of steroids. Most of the times they require low dose of steroids. You know, in fact, the tricky point is when we go below 10 milligrams,
Yeah.
and then when we are around of 5 milligrams. So I don't have, there are of course some patients in whom we need very high dose of steroids, but they are not so common. But I think that is rather what we call it corticosteroid dependency, that for very small dose of steroid. And I think that this is another problem. But I don't know, maybe with a new treatment that are on the way, maybe we will avoid completely steroids. It could be, but I don't think so also, but
We'll see. Yeah.
the promised land.
Good. Next question.
Hi, I have a question for the second speaker, Dr. Birnbaum. First of all, I really enjoyed your talk about exercise on myasthenia gravis, and I couldn't agree more that we should be very, emphasize very strongly to our patients how important it is to exercise, to remain active, for their long-term health. If you ask patients about their most disabling symptom, the majority of them actually say it's fatigue, the feeling of tiredness. And other studies on exercise in other neuromuscular disorders like CIDP, FSHD have shown that specifically fatigue seems to improve after exercise. So my question is, have you looked at fatigue?
So yeah, in MGX, we didn't evaluate fatigue. I'm not sure whether, do you evaluate it in your clinic or?
Well, we've just completed 2 studies into fatigue.
Okay.
And one of the things that we found is that fatigue is very strongly correlated to the amount of exercise that people have.
And was that in MJ?
That's in myasthenia gravis, yeah.
Oh, great.
On 400 patients with myasthenia gravis.
Which scale did you use?
The CIS, the checklist individual strength, which is a multi-dimensional fatigue scale.
Because the problem is finding a good fatigue scale is difficult, in my opinion, the one that's appropriate for MJ. It's not too long, that's relevant. And also the problem is we have to validate it in French. So we did validate the quality of life scale, but we didn't take upon validating 2 scales when we had the clinical trial to deal with. But I agree, I was very frustrated that we didn't have a fatigue aspect in the trial. And I think that it does need to be looked at. I agree. I really think that, and I totally agree with you. I think fatigue, self-reported fatigue, I think it's a huge issue for patients.
Fatigue is by definition self-reported, isn't it?
Sorry?
Fatigue is by definition self-reported, isn't it?
Yeah.
Yes, but I think there's lots of confusion between fatigability and fatigue.
I'm specifically talking about, the feeling of tiredness.
Yes.
And there are a number of scales out there, and I agree with you, it's sometimes difficult to choose which one you want to use.
Mhm.
The advantage of the CIS is that it's multidimensional, so it checks for different dimensions of fatigue, and that has been used in other neuromuscular diseases. So you have a kind of a background of what to expect. And if I may, one small follow-up question, because these other studies on fatigue actually found a long-lasting effect. Even 1 year after stopping exercise, people remain less fatigued. Of course, you didn't look at fatigue specifically, but in your study, the effect is quite temporary. And do you have any thoughts about that, why that may be the case? Or
Why the effects of the exercise intervention were temporary?
Yeah.
Because
were people encouraged to continue doing it after the program?
So not specifically, no, because there was the period of no training. I mean, we didn't tell people they weren't allowed to,
No,
but
exactly.
we collected the rowing machine. So they didn't have the rowing machine. And so they would, sorry. I mean, no jokes. That was really a complicated issue because we only had 4 and it was randomized. So we didn't know which, as we included patients, we didn't know if they were going to be in the exercise. arm, so it was really complicated to manage that. So that's just a detail. So we collected it. So there were also patients that typically didn't really exercise. So it's not that easy to then just start exercising. We didn't have a behavioral component in the exercise in the program. So it wasn't our aim to look at the long-term effects. It was really to look at the tolerance and the immediate post-intervention effects to see if it improved, because it was the first real clinical trial, a randomized clinical trial in exercise in MG. But I think that there's so much to do and to look at long-term effects. And if I'm really happy to talk afterwards.
Then I have to sneak in as a chair with a follow-up question. Why did you choose rowing machine? Because we have done a lot of studies before, and not that large, not so controlled with biking, with cycling. And that's something patients can do, and they continue doing it. So I'm really curious, why did you choose rowing?
So we wanted to have quantitative data of the activity. So we needed a specific, so we could have had a bike machine, but biking just does the legs. So
and you can do weights and other things for the arms.
Yeah, but then it's a multimodal. I mean, we wanted one program with the target heart rates. So we wouldn't have done that way. We could monitor it. So we could have just done a stationary bike and had the monitoring. But have you biked for 40 minutes on a stationary bike in your Parisian apartment? It's really not fun.
Yeah, but I was going to say, because I use rowing, and that's really more than 10 minutes. I wouldn't endure that long. So I'm quite impressed by the patience you have. 40 minutes rowing is quite boring.
Were amazing. 40 minutes of rowing is boring.
It's boring.
But it's a little bit more exciting than riding. I mean, I bike ride, but so bike riding outside is
I don't agree, but anyway.
So let's agree to disagree.
Yeah, it's okay to disagree. Sorry, I took the chance.
I mean,
yeah.
Anything in the four walls, I mean, ideally it would be better exercising in daily life. This was, a really controlled study. But the next step would be to do community exercise with accelerometers, etc.
Yeah.
Perfect, thank you. Great session, and actually my comment was for Simone and perhaps Tariq, because one is to do with the outcome measures. I think there is a really important outcome measure to consider would be glucose control and bone density, particularly with the use of steroids, and we know that exercise could increase the GLUT4 receptor expression and improve glucose control, etc. And the other one was to add on about the choice of intervention. I completely agree that having a behavioral component would be important. And I was thinking actually if it was something that was translatable to lead to persistence, and then you can then tag on another grant application to then look at follow-up 1 year later, for example, with walking, which is very accessible, and using heart rate monitor to assess what's the intensity. And I know that you aim for 70%, and there is a lot of nice data about zone 2, the lower range, and in terms of the benefits. So kind of your comments really and thoughts about that.
No, definitely. It's great. No, I mean, if anyone wants to collaborate, we've definitely got more exercise trials planned. It was really frustrating. It was there's so much to look at, but we tried to have a good methodological design because exercise trials are so heavily criticized, and we didn't have real data, high quality data showing that it was safe. So that was really our aim, without doing everything at once. But there's so much to do, and definitely happy.
Yeah, great work.
Mazen Dimashki, University of Kansas. Thank you for this great presentation. Simone, thank you for the great work you've done, and Tarek for supporting that. I think one of the underrated conclusions of your work is the fact that at month 9, you had 5 exacerbations of MG in the control group compared to no exacerbation in the exercise group. So there's more that needs to be done in exercise as a commentary. But my question to Tarek is about his study. I noticed that in your study of rapid steroid taper, you had 2,000 plus patients screened and you enrolled about 100. So are you concerned about generalizability of your data to MG in general, given that 95% of the patients screen failed?
It's true that we have looked at only patients with generalized myasthenia gravis and who required treatment with azathioprine and prednisone according to our guidelines. So I think, yes, it could be generalizable. And for instance, we are designing, I don't know if I answer to your question specifically, but we are just finished to design a clinical trial on steroid tapering in patients with ocular myasthenia gravis. we do not know if it will be accepted or not. But so I think that we will try to assess whether the rapid regimen is also that could be applied in other type of patient with less severe myasthenia gravis. I don't want to sponsor my very rapid tapering. You know, I think that the main message of our trial is to say that maybe we can do better than we can discontinue faster than we used to do. And I was really surprised by the efficiency of azathioprine, in fact, because I thought that it was not so effective, you know, and I was really surprised to see that in majority of patients, we can stop steroids within the first 15 months, which was not the case in the Palace study. So maybe it shows also that the way of physicians are of tapering steroids have this progress in some way.
Yeah.
I think that we are not doing the same. We are not treating the patient in the same way. We are more aware of the side effects of steroids like diabetes, etc. I think that this is what our study showed.
Yeah. And I think one of the important points of your study is that you can put patients on high dose from the beginning without fear of the early exacerbation.
Yes. Another, there is no, we were so because we have been trained as everybody here that, you know, pay attention to crisis or exacerbation after, you know, instauration or administration of high dose of steroids, but it was not so the case.
Thank you.
Thank you. Yeah, great. Next.
Thank you.
A few questions on Dr. Mupidi. I didn't see you analyze the thymectomy status on the outcome of COVID related MG.
Yeah, you're right. We have patients who've had thymectomy, about 40%. We haven't analyzed them by did they get thymectomy ahead of time and did that influence it? Part of the analysis that still hasn't been done is to look at the thymoma population. There are about 60 some patients. And Steve, I think is back there, I also suggested recently that perhaps that population should be looked at more detail because they might be at higher risk.
You mentioned 30% of MG worsened by COVID. And do you know what's the percentage of patients who required medication change for myasthenia gravis?
So if they had any worsening, out of that is the 30%. Out of that, you saw the distribution for corticosteroid increase, IVIG plasma exchange. There was a very small percentage of patients who required change in their pyridostigmine, but the rest of them includes that 30-some patients. All of them had some type of change. There were no patients who had a change, but there was had a crisis or worsening without a change in their myasthenia therapy.
Please fill in.
I have a question that maybe the audience.
What
about vaccination in patients with myasthenia gravis?
Yeah, so I had briefly mentioned that we, at least I'm guilty of not envisioning vaccination being available so quickly. So we never had that in the questionnaire. And the way that the whole process was designed, it was difficult to go back and incorporate if the patient has been vaccinated or not. But I had shown in the data that 2020 versus 2021. The reason we show that was, as a surrogate said, it's assumed that 2021 most people are vaccinated. Okay. So if you look at the actual numbers, there's less hospitalization in 2021, although statistically it wasn't different from 2020.
Yeah. Next question, please.
I've got a question for Professor Guyden. My question would be, I was wondering what would be the effect of thymectomy prior to the immune checkpoint inhibitors? Would that prevent autoimmunity or would that render the treatment ineffective?
If the patient has known myasthenia,
in either case?
Well, that's something I haven't thought about. You know, a lot of times patients, I don't know whether it would influence the effect of the immune checkpoint inhibitor therapy. I don't know the answer to that. In terms of practical management of, you know, patients prior to treatment, you know, a lot of times patients need to be started quickly on the immune checkpoint inhibitor therapy. There isn't, you know, time for thymectomy, and there isn't time to have the benefit of thymectomy in treatment of thymoma during the time of their cancer treatment. So I think, you know, we're looking for other alternatives to reduce the risk of exacerbation from a more targeted immune suppressant therapies.
Yeah, that could be done like a chemical thymectomy in that sense. My second question is, are you entirely convinced that the disease that we see is actually a humoral immune response there in the, so are the antibodies causing it, or is it T cells, cytotoxic T cells that contribute?
So I think, we definitely need additional study to say, for certain, but there is a very low rate of measurable autoantibodies, in this patient population, as the spectrum of disease has been recognized. So if we look at clues from other immune-related adverse events like myocarditis, which overlaps, it's predominantly T cell mediated.
So if it's myasthenia, it's a new form of myasthenia rather than a model for the myasthenia that we see in other conditions.
It's possible. So, that's why we were very kind of general, and it might be another form of impaired neuromuscular transmission. Correct.
Thanks.
Yeah. Short question.
Yeah, two quick questions, very short. Dr. Burwam, the control group in your study, we don't know how active they are, right? Thank you.
No, actually, no. It's an excellent point. So we're hoping to know how active they were, but at this stage we don't. But we did, yeah, we did. They did wear accelerometers at certain periods, but again, it was not easy to monitor the timing of everything. So during that 3-month period, yeah.
And Dr. Guidon, we other than myasthenia gravis, we actually encountered a couple of patients with, it's hard for us to decide whether it's a motor neuropathy or myopathy. So I don't know if you have encountered similar cases. Like, CIDP, GBS, like.
Yes, so absolutely, the neuropathy associated with immune checkpoint inhibitors does not need to be demyelinating. It's predominantly motor, and sometimes it can be challenging to determine. The needle EMG can be helpful in that regard, but it can be challenging.
Very short question.
Yeah, this is for Dr. Burman. So I'm not sure if you're aware of this. There are some studies about the effect of the exercises on the pneumatic junction in healthy animals.
I'm sorry, on the muscles.
There are some studies, yeah. So based on those studies, the different type of the exercise has very different effect on the pneumatic junction in animals. For example, endurance and the resistance trainings has opposite effects on the size of the pneumatic junction in animals. So I believe you should design your exercise, and their effect also depends on the age of the animals. So you should design your exercise based on this kind of knowledge. So you may have a different exercise for different group, the age group. So I believe that will help you design your experiment in the future.
Thank you. Yeah, I mean, from what I understand, from what I've seen, some of the animal studies, the dosage of exercise is possibly not possible in humans, but it's definitely worthwhile looking at it and being inspired by this important work. Definitely, it's a good suggestion.
Thank you. And to conclude, I think in the era of equality, you had 95% women. So I think we can conclude from previous studies also that men actually also improve upon exercise in myasthenia. So it's equally good for women and men, right? That would be a good conclusion of this session. Not only women should do exercise, but also men.
Definitely.
Yeah. Great.
Definitely.
Okay, so I think that has to round up the, with being on time here. I thank you all the speakers so much, and all of you for this very interesting discussion and attention. So rounding up this one, thank you.
Thank you. Thank you.
Hi, good afternoon. That was a fantastic 3 days of science, and I want to thank you all for such a fabulous week. And again, I know when I opened with you guys on Tuesday, I thanked you for making the decision to make the journey here and come here in person and participate and attend the conference. And I want to reiterate that again, we do understand that was a big decision. We're so happy that we were able to get together in person, and hopefully this is a whole new chapter for all of us. And on behalf of MGFA and our board of directors, and of course our community, our MG community, because that's why we're here, is for the patients and the caregivers, I do want to thank you for that. I do want to thank the folks who made this conference possible. So if I could just take a minute to do that, I think it's really important to thank people and tell them what they mean to you. So first and foremost, I want to thank the steering committee. And I actually, if you're here in the room, I would love for you to stand up and be recognized so that people know who the steering committee members were. So Dr. Kevin O'Connor. Dr. Carolina Barrett Tapia. And Kevin and Carolina were actually the co-chairs of the steering committee. So I really want to emphasize how thankful we are for their leadership. So thank you to both of you. Linda Kuzner. Rosen LaPonce. Anna Punga. Amanda Guidon. And James Chip Howard. Where's Chip? The steering committee worked hand in hand with a staff member who is absolutely amazing, and that is Dova Levin. And she was at the front here with me, but she moved. She's back there now. Dova's been planning this conference for a year with the steering committee. And she actually leads all of our conferences. So that's our National Patient Conference in February, typically in April. That our 5 regional conferences. She oversees a lot of our patient programming, and it's a very, very big job. And she multitasks like no one else. So thank you, Dova. Really appreciate your efforts. I want to thank our sponsors. You saw all of our sponsors out in the hallway the last 3 days, and they support everything that we do. And we just really appreciate that support tremendously. They show up and they're just always there for us. So really, really want to thank them. And I think some of our sponsors are still here in the room. Yes, here in the front, yes. And we certainly could not have this conference without the speakers. So I really just want to give a big round of applause for all of the speakers and their expertise in allowing us to lean into that. And for just, I mean, we couldn't have this conference without them. So thank you so, so much. I also want to thank those that submitted posters. And I should have thanked you along with the speakers, because that also is a huge part of this conference. So thank you to those of you who submitted posters as well. And I want to thank the rest of our staff. I told you almost all of our team has been here. They've been working out there. You've seen them there. Thank you so much for stopping by and saying hi to them. And they're all in the room now. So a big round of applause for the MGFA staff as well. And lastly, I just think it's really important to thank those who have helped you, and our partnership with the Hyatt. The Hyatt has been really wonderful. And so we've been working with them for the last year as well. So I do want to just make sure that I mentioned that the venue partner was also quite significant in this process too. So before we all leave, and I know some of you have to catch flights, I do want to say to you, when I talked to you on Tuesday and I talked to you about the role of the PAO in the space, and I called it a special one, and I mentioned that our work is all interconnected. I want to thank you because so many of you came up to me over the last few days and you talked to me about just exactly how our work is interconnected. And I thought that was really special. And I got to hear it and see it through your lens. And it was really, especially selfishly, nice to put some faces to the names. So thank you for having those conversations with me and for introducing yourselves, certainly. I just think it's really important that you know that it means a lot to us. So thank you. And I also want to thank those of you who cornered me in the elevator about the potential destination for the next international conference, because I got a kick out of that too. I really like that. So we started the list of potential destinations. We really do not know. We will decide in the next few months, and we will definitely share that out with all of you. But we really look forward to seeing you at the 15th International Conference, which will be in the spring of 2025, and it will be outside of the US, likely in Europe. So thank you for your recommendations. Keep them coming. You can keep reaching out and letting us know where you'd like us to hold the conference. And finally, I just want to thank you all. We really at MGFA, we really pride ourselves on being a convener, a thought leader, and certainly the preemptive source of information and education for the patient population, the caregiver populations. We could not do that work without all of you. And I just really want to thank you for your partnership. And again, it was such a pleasure meeting all of you, and I wish you safe travels home, and I can't wait until we see each other again. So take care.
A fireman with an hourglass, and in his pocket is a portrait of the queen. He likes to keep his fire engine clean. It's a clean machine. Then he lays